focus on the area of reproductive medicine. It's been almost to the day 40 years now since Louise Brown was born as the first child conceived with that technology, and it's believed that about more than 7 million babies have been born with technology since then. Ferring has been in this area for a number of years, have researched in reproductive medicine and women's health for almost 50 years. And couples are leaving it later and later, and so it's a growing topic for couples to conceive. There's a growth rate of 5 to 10% every year, so it's a very important area for Ferring, and we have a strong commitment to this area of research, development, and making drugs available or medicines available to couples who can benefit from it. Yes, I would say also we live in a global world now. For instance, in China, there's a large unmet medical need in this area. We know that the one-child policy has been kind of abandoned, and also with the demographic changes in China, there's a growing need for assisted reproductive technology to help couples to conceive. When we look at a global level, about 1 out of 6 couples have difficulties conceiving, and as I mentioned, because of career choices, etc., couples leave it sometimes later, and unfortunately with growing age it gets a little bit more difficult to start a family. But it's still a wish that's out there, and that we are committed to help couples fulfill. Yes, I think we've in medicine in general, we've talked about personalized or individualized treatment across therapeutic areas. Some also call it precision medicine. And the reason is that we learn more and more that the one-size-fits-all, at least in some disease areas or in some areas of medicine, doesn't work because people are different, they have different ages, different body weights, different genetic makeup, so it's important to tailor treatment to the individual. The same is true also for fertility. The idea between the fertility treatment is to use hormones to induce or stimulate the ovaries to produce oocytes or eggs, if you will. And we know that the response can differ quite significantly depending on the age of the woman, on the level of hormone that's called AMH or anti-Mullerian hormone. And we want to make sure that we don't underdose a woman, because that could then have not the necessary efficacy of the treatment. We also don't want to overdose, because that could come with safety tolerability issues. So to individualize treatment and to make the treatment more predictable will be important both for the fertility doctor as well as for the woman trying to conceive. Yes, I think this is on the heels of decades of research in this area, where we saw that there can be quite a different response of women to hormonal treatment. As I mentioned, some will only then develop a few oocytes or eggs, and others will have more than 15 or 20 and potential side effects. So the idea was to find a way to tailor the treatment to the individual woman. And as I mentioned, there's quite a body of scientific evidence that the level of AMH, this anti-Mullerian hormone, helps to decide how the response of the woman will be. So the idea was, let's tailor the treatment, let's decide on the individual dose based on the body weight of a woman, and also based on the level of AMH, and with that try to find the optimal dose for the individual woman, and to make, very importantly also for a fertility doctor, to make the treatment more predictable. So he or she can expect, with a kind of peace of mind, with a certain dose there will be a certain response of the ovaries. So it all starts with a hypothesis, as I mentioned, but then you have to obviously demonstrate that that hypothesis holds true also in a clinical trial setting. So the phase 3 trials, the ESHRE trials were, let's focus on ESHRE 1 trial for a moment. That was in more than 1,300 women, or more than 2,000 cycles, to show with an improved treatment that this dosing algorithm this individualized therapy actually works, as we had predicted based on earlier smaller clinical trials, and we're very happy to see that that indeed could be shown, that this individualized approach with Recovell was at least as effective as the established therapy with folitropin alpha. So that was important to demonstrate that the hypothesis actually works. The ESHRE trial was to look at is there any unforeseen immune response to Recovell. That also is something that regulators wanted to see, and again we were happy that we could prove that that was not the case, so that there was no unexpected immune response. So even with repeated use of Recovell, it should be a safe and effective therapy. So one was, yes, that it is at least as good, or at least as effective as current therapy, and there may be some safety tolerability advantages based on the predictability of the response. But let's focus for a moment also the new data that we're presenting at this Congress, where we looked at is there a change in the level of the AMH, the anti-Mullerian hormone, from day to day within a menstrual cycle or even between menstrual cycles. So if you want to predict the response on the level of the AMH hormone, and if there would be large fluctuation, then that would put at least a question mark behind that. So we were very happy to see that that was not the case, but that indeed in 95% of the women, the AMH level was so stable that there was a maximum one oocyte more, one oocyte less, depending on the level. And we are trying to receive 9 to 14 oocytes, so one of plus or minus one really isn't of clinical relevance. So we can say that those data really help to grow the confidence in the viability of this approach of an individualized and predictable fertility treatment. Yes, absolutely. So there could have been a question mark if you would measure the AMH level at different times in the menstrual cycle, or maybe 6 months ago, and if there would have been a various response, then people would have wondered, is this really something we want to follow? But with these convincing data that in 95% of women there was really no clinical relevance, or whether the AMH was measured 6 months ago or yesterday, I think really reassures fertility doctors and their patients that this is really a viable approach, the individualized and predictable fertility treatment based on an AMH level and body weight. So we're quite happy about the data. Yes, so the good thing about clinical trials is they often raise new questions and that can be answered with new science. So it's always important to further analyze the data. If you sometimes dig very deep, then you can only create new hypotheses that you then have to validate again in future clinical trials. We are currently conducting trials with Recovell also in Asia. We're hoping to start trials later in the year in the US. We're planning a larger trial also in Europe. We have an ongoing real-world evidence trial with Recovell, the profile study. And by looking to the data of the ESHRE trials, we can generate new hypotheses about further individualization. Can we identify other avenues to improve treatment success, which obviously would be important for couples as well as fertility clinics. And we don't even want to stop there. We also want to look beyond the pill, if you will. Are there other areas, genomics, big data, that we can use to help fertility clinics and patients to optimize therapy and increase the success rates. Yeah, it's still relatively early days. Recovell has been approved in 37 countries, and we've launched it in 17 countries, just very recently in Brazil and Australia, and we're about to launch in Canada. I would say the feedback is positive. I think the concept of individualizing therapy and making more predictable resonates with our customers, both with couples as well as fertility clinics. But but we know also from other therapeutic areas it can take some time for doctors to change their treatment guidelines and the way they treat patients. The way they've done it for many years. It sometimes takes a while, and constant scientific data flow and information to change behaviors. But we're convinced that the data that I just talked about will help us to provide fertility physicians with the confidence that this is the right approach going forward. Yeah, we're here with a quite large team because every Congress is very important to have that dialogue on a one-to-one and often in a medical-to-medical fashion, because then we can talk also about the science, about ongoing trials, and I think what has been commented on very positively is the commitment that Ferring has to the area of fertility, the number of trials, as I said, also going beyond the pill approaches to see what else can we offer couples to start a family. And also we've received comments on, we had just last week, there was in the New England Journal of Medicine publication of the Champion trial, because it's fertility is important, but it doesn't stop at conception. We also have to make sure that there's a good pregnancy and a good pregnancy outcome, and in collaboration with the WHO and Work for Mothers, we have shown that heat-stable capitation can reduce the number of postpartum deaths, and we're quite proud of that. And also colleagues here who read the New England Journal or read the press release comment positively on that. But overall, I think it's a good buzz overall at this Congress. New science emerging all the time, and the early feedback on Reproductive and the individualized approach is very positive. This is an area where it's a little bit more difficult to go to different patient populations. I think we have some positive data in the label on women with polycystic ovaries. I think that's an area where I can look into further. But I think the focus at the moment is to really convince that this individualized approach is the way of the future. Also, I would say we see that patients have more and more influence on their treatment decisions, and the personalized approach resonates also with patients, with couples. So our focus for, I think, for the next few years is communicating on the science around Reproductive. We look also at other treatments in fertility. We have a pipeline of products that we're pursuing, so there will be several focus areas going forward. Yeah, so I think it's very important, as I just alluded to, I think patients becoming more and more educated, talking to Dr. Google, if you will, which is good. I think it's good that patients, couples empower themselves, they want to know what's out there. We obviously have to be very careful as a company in the direct dialogue with patients, because we can never seem to promote our medicines, which is right, because that has to be done with a physician who can interpret our messages better. But still, there are ways to help patients to make material available. What could be the causes for them to struggle to conceive? Where can they find help? Where can they find a clinic to really make sure that they're not left alone, that they get support and knowledge and information outside of our drugs. But I think it's important for us to put the patients into the center and help them to cope with this. As I said, 1 out of 6 couples have issues, and it's important for us to help them. We've had Menopur on the market for, I believe, 18 years in 130 countries now. Reproductive, the individualized treatment. We're looking also at Menopur to make it more convenient in a pen. So there's trials ongoing. I already alluded to the globalization to run trials in Asia, in the US. I think that's important. But we're also obviously looking for new treatments. An important collaboration we've gone public with earlier in the year is together with the Chinese Academy of Science, where we will have a joint lab space in China, where we will look for new treatments and new ways to improve the success rates of couples who want to start a family. We're quite excited about that. China is obviously there's a large number of couples who need support. So there's a strong commitment of Ferring, both in the area of later stage clinical trials, earlier development, research in our research institute in San Diego, collaboration with external partners, academicians, and I think the Chinese Academy of Science is a good example of collaboration to find new ways of tackling that topic. I think maybe two topics. One is it's important for us to further improve the success rates. I think it's not an easy thing to go through a couple. There is uncertainty, there is treatment, and we have to work hard to improve success rates, and that can be new therapies, that can be individualized therapy like with Recovell. And as I mentioned, there can be other factors that we can use, like genomic data. The microbiome learn more and more about the microbiome, also in the field of fertility. So increasing the success rates through various avenues will be an important one, and it's still a challenge. And the second one is that not all couples have access to fertility treatment. That may be cost, that may be because they live far away from a fertility center, that may be because they don't know the options that are out there. That comes back to your earlier question. It will be important for us to support patients with information material, to help them learn where they can find help, and that they're not alone in that, and that there are options for them to get support to start a family. So I think the two things: further increase success rates, even though they're quite good already, and the second one, to make sure that couples have access to the best and most modern treatments. I think will be two important challenges to continue to tackle in the years to come. So obviously we now live in a digital world, I think that's a great tool to use. Again, importantly, following all of the legal and compliance framework, because we don't want to do anything that we shouldn't do. But I think the internet is a great source of information. We also work with patient advocacy groups in a number of countries who have maybe sometimes better access to couples and patients, but again, we can support them with material, support them with their congresses. Just yesterday, I met with the International Federation for Fertility Service, which is like a global organization which works with 70 different countries and sponsors congresses also in areas, like they just had a congress in Lagos, and they have one this year in Panama, and they're planning one in Ghana, because this topic is not restricted to Europe or the US. There's couples throughout the world, and in some areas there may be even a bigger stigma for couples not to be able to start a family. So it's important for us to use these patient advocacy groups, the federation, the internet, to make information available to patients. So I mentioned already the microbiome. I think it's something where the scientific data is just exploding. We learn more and more how important the microbes, the bacteria, and other microbes that live in us, what influence they have on human health and disease. Just a couple of months ago, I was at Imperial College in London, where Ferring is, through the March of Dimes, supporting research into the role of the microbiome in premature labor. Premature labor is the number one cause of death for children before the age of 5, so a very important area to study as well. So there's a lot of exciting areas. I mentioned genomics, there's the microbiome, there's big data, artificial intelligence, what can we learn from that? So it'll be important for us as a company to keep our ears open, to work with others, to collaborate, and use this new information, these new tools, these new areas of research to find new ways of helping patients to conceive. I think an important one is to not fall to the hype. Sometimes, something gets really hyped in the media, and then we realized 5-10 years later, or maybe it took a little longer than expected. So we have to kind of be excited about new areas, but not be overexcited, and stay with the scientific data. At Ferring, we have a unique chance. We're running and starting a number of trials, as I alluded to, so it's a unique chance in several thousand women to combine the data with our medicines, with big data, with information about the microbiome, genomics, and we've started a number of collaborations in this area, and we're very excited and optimistic that we can find new scientific data that can help us to increase the success rates and to have more couples to start a family than we could maybe